It is great to actually see people at the other end of the referral spectrum. I spend a lot of my time, I do large-scale clinical trials as my research, and I spend a lot of time going around the country trying to incentivize other liver doctors to keep going with the trials under all the increasing pressure of workload. So I talk a lot to liver doctors throughout the country, but much less so to people actually seeing most of the fatty liver patients. And of course, liver disease is a curious specialty in that our inpatients have a very limited life expectancy. Those with cirrhosis and ascites, perhaps 2 to 3 years, half of them will be dead. Yet many of those we see in clinic often are not going to die of liver disease and actually more likely to perish from cardiovascular disease, diabetes, or non-liver malignancies. And that requires quite a differing skill set, I think, in terms of risk assessment and, of course, critical care, which is kind of what I grew up with as a junior doctor. And I'm not sure we do it very well. I'm hoping we'll get better. So let me take you through. And that leads nicely into how much should I worry? We have an explosion of obesity. Everyone knows this. And 60% of adults are overweight. Lots of these will have deranged liver blood tests. Yet relatively few are actually going to die of liver disease. And you guys can't see all these people. We can't see all these people. So what are we going to do about it? So here's what I think we should do in the interim. But I do think a longer-term solution needs to be found. So, conflicts being so yeah, some years ago I did this exercise with Novartis where we predicted what the best drugs would be for emerging NASH therapies. And I think we got it right, actually, but we'll come on to therapy at the end. So the scale of the problem, I've already alluded to this. It is overwhelming. There's no question about that. And progression, this is really the challenging thing. This is what we should be worrying about. Who are going to progress? And I'll hopefully cover in a straightforward way. I'm not going to talk about some complicated biomarker or some stool test that costs £10,000. Readily available NHS-funded blood tests can do the job for us. What we do in hospitals, to give you some idea of the route thereafter, diet. My son, who's only 9, said to me, "Dad, why do you do a job where only a third of people listen to you?" And he meant the patients, not my colleagues. It's far less with my colleagues. And he had a point. But I said, I'm an optimist, son. So that was my only answer. Medication, because it's coming, it's going to be expensive, and I fear it is the wrong way for the majority of people. And associated conditions, which you guys manage much, much better than we do. And I think that it's always important to get this message across, that cardiovascular, diabetes, high blood pressure, etc., are the key things for the majority of these people to be worried about. And the future, not too much on that, because I think we've all learned in the last few years not to think or predict that. So the problem. So I'm older than I look, which is to do with my dear mother inheriting her genes. So when I was a kid in the 70s, 2008 AD was something all the boys read. We later found out that girls weren't really interested in boys who read comics, so we sort of secretly read them. So 2000 AD was this sort of dystopian future, and Judge Dredd was this sort of anti-hero. But I always remember this belly wheel that was for people who were overweight, and they had these competitions, and people tried to eat to win. And I remember thinking, this is just madness, And sadly, and of course, that sort of picture, thankfully, we don't see. But I have seen people who can't get out of their house. I've done telephone consultations with people who can't get out of their house. And how did we get here? I just don't. It worries me, but can't change the past. So the bad news, and the Lancet Liver Commission did a lot of work with Roger when he was alive about promoting what's going wrong with liver disease. It was very good on description, but we need to act with implementation. And so 60% of adults are overweight, I think we all know that. Liver disease will soon overtake cardiovascular disease as the leading cause of working life lost. Now, that's because the median age for sort of falling apart, developing ascites, is around about mid-50s. I did a large trial, and I think the median age was about 52, which is depressing, isn't it? So it hits people when they're of working age, whereas cardiovascular disease, obviously, is more in retirement. They came up with some modelling. Everyone's a modeller, of course, and a figure of preventable deaths, which is pretty staggering. And, of course, the cost. And that's not going to go away. But the good news is, of course, most people will not develop significant liver disease. And the question, of course, is how do we differentiate between these two groups of people, and what should we do? Next one. And this is an older slide, actually. Yes, so this is an older slide, but it still rings true, really, is this sort of tip of an iceberg. Now, you've got to remember, a lot of the people who publish in these things are enthusiasts, by definition. To be a clinical academic, you have to be an enthusiast. And so they're trying to tell a story. And of course, the story around this paper is that we're not looking after enough. Now, of course, you could flip that and say, well, we're overwhelmed as we are. What are we going to do about these extra 60%? But I think this will come as no surprise that it's all about the ALT blood test in terms of identification. And a fifth of those identified will get a diagnosis. A few more will be advised about lifestyle. How many, of course, take that advice, I'll come to in a bit. So really that's how we often identify these people to begin with. It's not a great strategy, but it's a cheap and cheerful blood test, and they're always usually done for other reasons, of course. But of course, to paraphrase George Orwell, not all NAFLDs are made equal. And there's a massive interpatient variability. People get better, people get worse, and how on earth are we going to monitor these people? And won't do too much on histology. I never go to histology meeting. I kid myself perhaps that I don't have the time. And I think perhaps I'm not a proper hepatologist. I think in my soul I'm probably a sort of clinical trial and public health type doctor, but I chose the wrong career maybe. But anyway, so I don't know much about liver histology, but this is just the basics. So this is a healthy liver. This is what we've all got, I trust. And you've got these lovely hepatocytes here working beautifully. And then this is a fatty liver. This is your foie gras if you're holding in the Dordogne, which I did it once. It was great to begin with, and then no. And I mentally just can't do it now. And this is the fat gets deposited in between all these healthy cells. And most of us, if this happens, doesn't really do very much. Our hepatocytes seem to live alongside these fat cells quite happily. But these are the people we need to worry about. These are the people whose liver cells don't sit alongside happily. They become irritated. They become inflamed. If you think of it like a burn, they're being constantly burned. This is what I tell patients in clinic. Liver disease is a series of burns. You get a burn, it goes red hot and tender. White cells rush in, think the body's under attack, heal it down, leave a small scar. And this over and over and over again will lead to fibrosis and then cirrhosis. And this is the cirrhosis, these nodules you get, and or rather, this is fibrosis. Rather, you get these horrible nodules, and that leads to cirrhosis. And now, of course, even cirrhosis, many people are asymptomatic. I've got lots of people, in particular with NASH cirrhosis, who are asymptomatic. They come for screening because there's a sort of 1% risk every year of getting a liver cancer, and so cancer doubling time is about 3 months, so we screen them every 6 months. Not sure it's that cost effective, but it's dogma. Can't challenge it. And these people are often fine working, or if they've retired, they don't feel unwell. And these people, on average, if you take a huge number of them, and this data from the 90s now, will have a median life expectancy of 10 to 15 years. So even those with cirrhosis, their liver lifespan, if it's later on, is not as bad as you might think. It's those who get decompensation. It's those that get ascites, get jaundice, get variceal hemorrhage, and become unwell, almost always present to hospital. These people, all of a sudden, they fall off the health cliff. They go from a life expectancy of 10 to 15 years to a life expectancy of 2 to 3 years. And that's what we really need to try to prevent. So, what do we focus on? Well, inflammation. UCL loves inflammation. There are all sorts of definitions, but the burn analogy is probably as good as I can get. And as you can see, it's funny, without advanced fibrosis and with. And as you can see, those without do pretty well, and those with inflammation, almost all of them will develop advanced fibrosis over a sort of 10 to 15 year follow-up. And this is similar, but it perhaps more clinically relevant, because inflammation, can't do a test for inflammation very easily. So 80% or more will have this isolated fatty liver. And really, these people, by and large, are going to do fine. No real increased risk, according to some studies. The data is conflicting, or are conflicting even, and there will be some studies supporting a slight increased risk, but it will be low. So by and large, these people are going to be fine. There'll be a few with mild inflammation who do progress down here, but that may be, liver biopsy takes a slither of tissue. There may be some sampling error there, and that it may just be misclassification to begin with. NASH, so this liver cells, irritated liver cells. So less than 20%, and then 11% of the 20% will progress over a 15-year period to cirrhosis. And 7% of the 11% of the 20%, which is about 1% per annum when you get cirrhosis, will progress to hepatocellular cancer. And a third of those with cirrhosis will progress perhaps over a sort of 10-year period to this cliff face of decompensated liver disease, most commonly ascites. So they're the figures. So most people are going to do well. And this I find really difficult to get across to people, is that the individual risk is pretty low. But there are so many people who are sadly very overweight and it's affecting their liver that on a population scale, we are talking about an epidemic. So I find that very difficult to explain to people, and it probably makes me less effective. They probably stop listening to me if I go on too much about it. So I need to come up with something better, I think, when I'm talking to the individual in front of me. And these people do have increased risk. Now, and this is bad news for them, but good news for us, that their increased risk of death is largely, number one, cardiovascular. And there are things we can do about that. Statins, aspirin, clopidogrel, proper assessment, hypertension, etc., etc. And we know that these actually work. There is good evidence base for all of these things. The history of clinical trials, the statins, etc., are way up there. So we can do something to help. And, again, this really is to, I'll come on to it again. We're not yet taken over by the machines. There is clinical acumen there somewhere. And if there are risk factors that you can identify clinically, and these tend to be diabetes, increased weight gain, rising blood tests. So what can we do? As I said, most people are picked up on either routine ultrasound surveillance or blood tests for another reason. And someone goes, oh, they're up, I'll repeat it again in 3 months. Oh, they're up, I'll do a liver screen. And this is common practice, we all do this. And global prevalence of 25%, it's a lot of work, especially if you kick the can down the road. I think we do need to find a different way to do this. Nevertheless, this is what most of us will do. And really what we need to do, I think, early on is this distinction, because liver-related death 10 times higher, cardiovascular death double in these people with NASH. Third of them will have fibrosis, which is bad news for them, but good news for us in terms of being able to identify them. And as I said, just to reiterate that the complications of cirrhosis, though devastating and outside of transplant, still no effective therapies. I'm hoping one day I'll be able to get there and put my hand up and improve things. Actually, eClinMed, which are one of the things they've just published our beta blocker paper. There may be a trial there. Anyway, so that's my personal ambition, to try to improve things. But at the moment, decompensated liver disease, outside of stopping drinking, and we're not talking about drinking, we're talking about NASH, there are no effective therapies aside from transplantation, and that's for the very few. So we want to prevent it. And some get better. You know, there is some good news. Some do. Nightmare for designing clinical trials, of course, but good news for the patient. And we can't biopsy everyone. You know, risk of 1 in 200, so it's a relatively low-risk procedure, yet no one enjoys it, of course. But of course, the patient is in hospital for monitoring thereafter. It's usually done by a consultant radiologist. There are real cost implications for liver biopsy. So what can we do? And who to worry about? So it's all about fibrosis, all about scarring. And we can do something here that is cheap and cheerful, thank goodness. The routine liver blood test. Now, I know not everyone gets an AST, and I know that has to be asked for in many places, which messes up things, I appreciate. And I appreciate also in some primary care, you tick the liver blood test and you only get the alkaline phosphatase. So I know this isn't as straightforward as we perhaps like to pretend. But FIB4, and again, it's online. Those of you who are much better at maths than me may be able to work that out. My daughter probably could, but I'll cheat and use Google for this. And these are very good at identifying low probability and high probability. They're very good at ruling out someone without liver disease and someone with a high probability of liver disease. Less so the middle. As I say, please remember pre-test probability. The machines aren't quite yet ready to take over our clinical care. And also remember that the trials are often designed with an enriched population. There'll often be tertiary referral patients already because it's easier. Doing this work in primary care is much harder. And so the unselected populations like the ones that you all see, some of these haven't been as validated as well as we like to pretend. There's also the ELF test, which will be available to some of you, many of you, which was designed by one of my colleagues, William, up at the Free. And again, this is useful. Again, I think this slightly historical slide, I think 10.51 is one of the cutoffs now. And it comes with a readout. So if they shift some of the figures, you don't have to keep up to date. And so this is helpful too. And again, it's a blood test. And the dermatologists have been doing procollagen 3 peptide for years for people on methotrexate. So these things work. Blood test, one blood test. This, obviously, very inexpensive. This, a little more money. And how best to use them? Well, there is good data. There are meta-analyses on this. There's also a number of papers saying that just looking at the ALT doesn't necessarily help. So I think this is the way forward. And many of you are doing this anyway. And Camden, Islington, those of you who are up the road, this 2-test sequentially approach, FIB4 followed by ELF. So FIB4, low, high, refer, or discharge. Sorry, it's a bit grotty, the slide, do forgive me. The intermediate ones, ELF test, low, high, refer, discharge. And this did reduce referrals for what were considered on the testing. So again, it's sort of the bit of reverse engineering here, but nevertheless, a good measure outcome. Reduce the referrals for those without fibrosis by 82%, increase the referrals with cirrhosis 5 times, and increase detection of cirrhosis 3 times. And the European guidelines recommend transient elastography, and there may be some conflict of interests around why they do that rather than a simple blood test. But anyway, so I think this is helpful. It is good at identifying the people with fibrosis. It perhaps forgets that we're missing the message here. We're just identifying people. We're not doing anything about it. But nevertheless, we are looking to try to reduce the burden of these people, and I think this is a helpful approach. Now, what do we do in hospital? Well, we largely rely on the FibroScan. I think one of the problems with the COVID pandemic and the approach for the backlog is that we're doing these sort of telephone clinics, and which means that the patients are getting all the tests. They're getting it's like America. They're getting a FibroScan, an MRI, blood test, etc. before they come to see us. It makes our job much easier, but I don't think it's very cost effective. I do think there needs to be some human contact fitted in here. But nevertheless, this is the approach we're all taking. The elastography, impedance, if you're a mathematician or physicist, or the patient is and you're explaining it to them, sponginess. Healthy liver's like a sponge, unhealthy liver like a stone. And this fires an ultrasound wave and measures that. And it's useful. Morbid obesity, and you can do it on pretty large people, there's no question. The technicians are obviously pretty skilled at this. It only takes about 10 minutes to learn. It's not a difficult thing to do. But it is very good. Again, these are some of the readings. Essentially, anything below 7 is pretty fine. And alcohol, 9, and NAFLD a little bit lower, 8.5, you begin to worry. So this we rely hugely on in secondary care. But it doesn't obviously look at the inflammatory cells. It doesn't detect NASH, it detects scarring and detects fat. That's what it does. We extrapolate that NASH equals scarring, and we focus on these people. But it doesn't measure NASH. Liver Multiscan, Perspectum, they're quite a enthusiastic company about their product. It's not ready for real time, I think, yet, but this may come. And they've got some data, more coming, about its detecting the future, sort of MRI-based technology. But of course, it ain't going to be cheap like platelet count, AST and ALT. So where this sort of thing fits in to the future management, I'm uncertain at the moment. But as I say, they have an enthusiastic team, and I'm sure we'll hear more about this. So treatment. So what do you do? And this, of course, I think is challenging, that we all know. And we sort of talk about risk assessment, and that's fine. But actually, surely the message should be to everyone, because surely that has to be a better approach. Just tailoring your advice to someone who's got advanced fibrosis, it makes no sense to me. So although I stand by the Cameron Islington, the guys who did that work, that's terrific work, I do think we're slightly missing the point of the exercise, which is to try to get people healthier. So how do you do it? I had a patient come to me in clinic a couple of weeks ago and said, Dr. O'Brien, I want to look like you. I didn't have the heart to tell him he was 5 years younger. I said, no, you don't. I said, there's no, people who do a lot of exercise are not necessarily going to live any longer than those who do a modest amount. It's the difference between those who do none and eat too much and those who do a modest amount. And I tried to get that across, but anyway, we'll see. It was slightly scary when he said that. I'm not sure, and I'm not sure what the message, I think this is really difficult. Years ago, I sort of used to say to people, what I did. But I don't think that helps. They don't want to hear, what I did. They want to hear what can help them. And they haven't come to clinic to be insulted. They're human beings. You can't. Dear old Roger, God rest his soul, used to say, you're fat, you're going to die. Both of which, of course, were true, but neither of which were particularly helpful. And I inherited a lot of his patience when I started at the Royal Free. And so I said, did that help? No. So I don't do that. But I'm not sure my softly approach helps either. So I'm a bit stuck. And I always ask everyone who loses weight, very few sadly, I always say, how do you do it? And they always look at me as if I have two heads. How do you think we did it? And there's the challenge. We know the answer, but actually communicating that message, incentivizing people, is that really what we went to medical school for? We haven't been trained. I know nothing about behavior. Perhaps it should be incorporated into the curriculum now. Perhaps we should have postgraduate sessions on changing behavior. I don't know the answers here. But what I do know is that what we're doing now has limited effect. But if they do take our advice, then it does work. 7% reduces fatty infiltration and inflammation. The drug trials, the FDA-approved endpoints are reduction in fibrosis, reduction in NASH. So we've already got a really effective drug that's cheap, but people aren't taking the pills, are they? Mediterranean diet, again, I said, the Mediterranean diet, and they said to me, what's that? I was like, oh, come on, please, this well-educated youngster. I said, you must have heard that, Mediterranean, Southern Mediterranean. No. And I do think there's some obstinacy here, and whose responsibility is this? And it's irritating. You mustn't show your irritation. That achieves nothing. But I was like, oh, come on, you must know. Oily fit. But there is a lot of that. Carbohydrates does work. Everyone always sort of says to me, I've given up bread. Well, Hollywood actresses probably don't eat a lot of bread because it bloats them, but for the rest of us, bread's quite nice. Don't think it's the devil in terms of food. And they all say I've given up coffee. Now, I recently gave up coffee. That was more to do with staining my teeth. But coffee actually is probably slightly good for your liver. They've done a lot of sort of studies, and they poured them into a meta-analysis. Low quality. Italian, because of course Italians love their coffee. But you talk to an Italian liver doctor, coffee's great. It's easy to give out conflicting messages. So Mediterranean diet does seem to work. A more plant-based diet does seem to work. But people know this. I say, look, it's what your mum told you growing up. It's not different. The 5-2 diet, of course, works because it restricts the calories, but it's difficult to stick to. I couldn't do it, and I'm very loath to say something that I can't do. With alcohol, I was giving all this advice about trying non-alcoholic stuff, and I thought, well, I better do that. So you've got to practice what you preach, and I couldn't do that, so I don't advise it. Sugar is the enemy. The marketers are much better at this than we are, and low-fat muffin, it's like, but it's still packed full of sugar. That is not a good thing to eat. Enjoy it, do it from time to time, but that is not something to have every day. And activity, 120 minutes, that's 4 times 30. That's quite a lot of activity. Most people would struggle to fit that into their day. So again, that isn't easy. And we talk more and more about strength training, don't we? Sarcopenia of age and strength training. Now, these are not high-quality studies. There's no pharma backing, is there? The NIHR are not going to fund big money on these sorts of interventions. So we all know it's common sense, but it's not grade 1 evidence. And the strength training has become quite fashionable. We'll see. We'll see. And this is the pyramid. And of course, this is great. Look, tiny bit of weight loss gets rid of most of the fat in at least a third. This is the irritation. 5%. That's not that much, is it? Gets rid of that. NASH, as I say, this is the FDA-approved primary endpoint for the drug trials. 7%. It's not a lot. 10% is the magic number. That really is when we're in business. But this is, and that's not my clinic. I fear it'd be even worse in mine. But that's what we're dealing with. And as I said, I think we need a slightly different approach, and focusing on behaviour change may be that approach. But I'm not an expert on that, I'm afraid. So, who should deliver this message? So I'll do this one first. So when I was a kid, I remember going into the GP surgery for some check or something, and I remember seeing this on the wall. And it's still true today, isn't it? This is what we face, isn't it? What do you do with that? I get it all the time with alcohol as well. I have this lady, she was early 40s with ascites. And she said, I'll cut down. And I was like, you can't cut down. This has to be over. Well, I'll think about it, Doc. And I just had my head in my hands. I was like, you're in the prime of your life. So we can keep doing this. We can keep doing this. And this is, so again, the Royal Free, the dietitians will see the very advanced liver disease patients on the transplant list. But they won't see your bog standard fatty liver patients. And this is obviously a service delivery issue. It's just we don't have the staff. And I managed to sneak someone in. They actually got seen. I think they must have misread the referral or something. So I took a photo of the advice. And I've kept this. And it's not a criticism of the person doing that, but I'm just not sure that's a convincing message. I'm just not, I don't see it, and these people come, what's the diet, and I'm sort of going, well, eat less, and this is when they actually, the few who get through to a dietitian, that's what they get. I'm not sure we're going to win that. This is something we can win. So I remember when I was a junior doctor, I won't say who it is, he's retired recently, said to me, look, there are two types of NASH, those that admit that they drink and those that don't. And he's not quite true, because those are certainly who work in populations with a lot of Southeast Asians. We know that they by and large don't drink, and NASH is a big problem. So it's not quite true, but it is important to address it. Lots of people drink more than they admit. We've always known this. When I was a medical student, it was like double the amount people admit to. And 14 units a week is hard. You're essentially a non-drinker. 14. I'm essentially a non-drinker, and 14 units. A couple of pints of lager is 6 units. That is hard yards. Dame Sally Davies I have utmost respect for. It was under her tenure when they came up with reducing it, of course. And I get why they did it, but I'm just not sure that's something that is sellable for a lot of people. I'm not sure. I'm not sure what the impact of reducing the units was, because most people say, I can't do it, I'm going to ignore it, Doc. But it is important. The effects of alcohol multiply; they don't add. So it is important. And most of the people I've had over the last sort of 5 years who've progressed, anecdotally, which I shouldn't be, should be firmly evidence-based, but I'm a human being too. Anecdotally, they've all lied to me ultimately about drinking. And it's when I say, look, you're cirrhotic, they go, well, I do like it. I had one guy with massive ascites, and I've been saying, stop drinking. And he saw me again. He's had ascites for 15 months. He's been on dialysis. You'd have thought he'd have, penny would have dropped. He said, well, I've only just stopped, Doc. I was like, you're lucky to be alive. I really hope this gets better. People are people. Yeah. What can you do? It's a bit of hepatologist. You've got to be an optimist. And do check for viral and autoimmune. It'll be a tiny, tiny number, but it is worth checking for. In London, one of the great things about living in London is this diversity and multiculturalism, and we've got lots of people who come from Southeast Asia and Africa who may have been exposed to hepatitis B at birth, of course. Drugs. This is a tricky one. So this is recommended. The NICE guidance still recommend this. I don't think many people do it. I'm not a diabetic. I never did a diabetic job, actually. So I feel particularly ill-equipped to prescribe pioglitazone. And of course, people put weight on, and the majority of people don't like that. Vitamin E, it's easy, you can get it over the counter, of course, but as soon as you stop taking it, things go back, and there is a slight increased risk of intracerebral bleeds and in men, prostate cancer. So, you know, so I don't prescribe these. These are NICE approved at the moment. The NICE guidelines are from some years ago. I think they're waiting for approval of some of the newer drugs before that committee reconvenes, I suspect. The PPAR gamma, this is PPAR everything, isn't it? Yeah, pan-PPAR. So this is pathway. You know, PPAR. If you want to do a molecular PhD, study PPAR because it's one of these sort of ubiquitous pathways that's affected by any inflammatory process. Which means, of course, that when the drugs have been developed, they often have quite a lot of toxicity. So it's a hard area for pharma. But these have worked. So they may be coming. Obeticholic acid, so this is used at the moment for primary biliary cholangitis. So it's effective there. And in an increased dose, it's been shown to be effective in fibrosis. But it's expensive and causes itch, especially at the higher dose. Semaglutide, you know, this is going to be the world beater, the world's first effective anti-obesity drug. Not quite ready for prime time yet. Metformin, Urso, and Orlistat don't do anything. I know Orlistat we don't do anymore. But Metformin obviously has effective value for impaired glucose tolerance and type 2 diabetes. Urso, don't bother. This is from the internet. This isn't one of my patients, so it's freely available. And this is what's being promoted. You know, this is, you know, those of you who go on Twitter, semaglutide is on Twitter. You know, the actresses and actors and movie stars and rock stars or whatever who suddenly lose a lot of weight. I'm very suspicious that they've had a bariatric procedure and they're on semaglutide. You know, this is coming. You know, people always ask, you know, Doc, can I get you? Because you lose 15 kilos. A lot of weight, and I'm not sure if that is the same person. There's slightly glossier hair and younger-looking skin, and where I don't think it gets rid of your freckles. You'd be proud of your freckles. But this is the sort of stuff that's out there, and our children will be exposed to it on social media. I think even Elon Musk said something. He says a lot of things, of course, but but you know, who's going to pay for this? How long are these people going to be on it for? Because we all know that man will find a way, and the weight will come back on. And who's going to be eligible? So these are really important questions. But it's there. The New England Journal, they had a paper in NASH. They had a paper about obesity. You know, everyone knows. So we'll see. But there is good news. There is. The stuff you guys do is better than anything I do. So, you know, these people have adverse lipid profiles. So statins, fibrates are useful. Statins, by and large, are safe. If the LFTs are up, rule of thumb, start if there's no other contraindication. If the LFTs double, probably stop then. But you've got that margin. And you can try other statins. You know, if you start with Simva, you can try atorvastatin. So that is a good thing. We know that these drugs work. Hypertension, that's something that obviously we have effective evidence-based medication for. And there's some talk around sort of ACE inhibitors improving fibrosis. That is not proven at all. So please don't feel under any pressure to change your practice if you hear someone talk about ACE inhibitors and fibrosis. That story's been knocking around a while and as yet remains unproven. So we'll see. Glucose intolerance, again, you guys are masters of this. This works, of course, and as I said, number one killer for these people is cardiovascular. And vascular inflammation, again, you know, aspirin, clopidogrel, etc. So there are good medications that in the majority of these people are going to extend their life and treat problems that we know how to treat. So never forget that. I'm sure you don't, but that's the best thing. Because we, of course, don't do it in clinic, do we? We write something fairly unhelpful, like, oh, please attend to cardiovascular risk factors. Forgive us. We don't mean to be unhelpful. We really don't. And certainly from my perspective, you guys are doing more than I do. And I think that is a serious point. So to conclude, this is a common condition and I think needs a common sense approach. These people are asymptomatic. And of course, that is difficult, isn't it, in terms of incentivizing people. It's a big problem about liver disease per se. People with cardiovascular disease get chest pain. They go to the doctor. People with respiratory disease get breathless, which is a terrifying symptom. Go to the doctor. So they're primed for something. Most of these people, it's us telling them there's a problem that they didn't know about. And that's a challenge. At the moment, fibrosis, FIB4 ELF, bang. That will sort out the majority. The in-betweeners, don't forget clinical intuition, guys. You're all intelligent, well-trained people. As I said, algorithms aren't quite ready to take our jobs yet. And again, just to reiterate, cardiovascular morbidity and mortality is more important for the vast majority of these people. I fear the future is geared towards ever-increasing medicalisation of obesity. I do think this is a mistake from my perspective. I think from a cost-effective approach, surely a public health joined-up thinking approach is best. But we all sit, public health sit here, primary care sits here, hepatologists sit here, and we rarely talk to each other. And it's the same with alcohol services. We spend, it costs £9,000 for the average admission to hospital with a decompensated liver disease. Yet we send people home. It's up to you, go to AA. It's just maddening, isn't it? It really is. And I fear that we'll be looking at the same for NASH over the next 10 years. So I think we do need to join up. There are people working in the community. Nottingham do this. There is a Royal College of GP champion for liver disease. So it is being addressed, but it does require funding. And I do think that this would be the cost-effective approach for the future. Thank you very much.